Endophthalmitis is rare but devastating, blinding complication primarily after intraocular surgery. Endophthalmitis comes in the differential diagnosis of leukocoria, can be acute or chronic. In this video, we will be discussing common causes, investigation, treatment plan, common complication, risk factor and their prophylaxis. You can appreciate white plaque on the posterior capsule, and patient came for second opinion, was treated 3 months ago somewhere else for postoperative endophthalmitis. On slit lamp, its first appearance looked like nuclear sclerosis. In this case, the only option left to clear the media was the pars plana vitrectomy. This can be exogenous or endogenous. Exogenous, most common cause is post-operative any intraocular surgery like cataract or glaucoma, or post-traumatic. The most common organisms are Staph epidermidis or Staph aureus. Endogenous due to generalized septicemia or localized infection, endocarditis, pyelonephritis or osteomyelitis. Non-invasive investigation of choice is B-scan to see the vitreous activity or the retina status, degree of vitritis or integrity of retina, to see the response of treatment or success of therapy. AC tap or vitreous tap and biopsy with simultaneously intravitreal antibiotic injection. For culture sensitivity and PCR in case of chronic cases. Conjunctival swab can be taken for culture sensitivity. Early diagnosis and treatment is the key. Number 1, hospitalize or admit the patient. Number 2, intravitreal antibiotics, especially within 24 to 48 hours, or anterior core vitrectomy with intravitreal antibiotics. Only multiple drops is not an option in such cases. Number 3, topical or fortified eye drops. Number 4, intracameral can be an option, or periocular injections can be an option. Systemic, oral or IV antibiotics or corticosteroids role is controversial, but management varies case to case. However, early intravitreal antibiotics within 24 to 48 hours or pars plana vitrectomy as per endophthalmitis vitrectomy study have a better prognosis. Overall outcome depends upon duration of infection, prior treatment and presentation. Number 2, virulence of organism. Pathogenesis is the toxins produced by the infecting bacteria, and the host inflammatory response cause rapid and irreversible photoreceptor damage that can continue long after the ocular contents have been rendered sterile. It's a clinical diagnosis based on history and clinical examination. Signs symptoms are pain, worsening vision, increased post-operative inflammation, AC activity or hypopyon, posterior segment inflammation like vitritis, fibrinous exudation, impaired fundal glow, loss of red reflex, lid swelling, edema, chemosis, cornea may be hazy, RAPD, inaccurate light projection suggest poor prognosis. Risk factors are patient flora of conjunctiva and eyelids, having blepharitis, conjunctivitis, and LD disease, age over 80, comorbidity like diabetes, complicated or prolonged surgery or surgery having a combined procedure, contaminated instruments, OT, air, surgeon or staff. Prophylaxis include careful wrapping, 5% povidone iodine, 5 minutes before surgery, intracameral antibiotic injection, post-operative subconjunctival injection or intraoperative infusion having antibiotics. Chronic post-operative endophthalmitis usually requires pars plana vitrectomy with IOL and even bag removal. Common complications are vision loss or blindness, glaucoma, or phthisis bulbaris. Ceftazidime can precipitate with vancomycin, so separate syringe is used. Intravitreal injections are explained in a separate video. Thanks all patients for their consent and cooperation.